series. Welcome also on behalf of Sonja Rasmussen, who will be giving the second part of this lecture, and she will be focusing on vaccines, booster doses, and of course she will update us a little bit on children. So I am glad to be here and to be able to update you on what is happening around the world with COVID-19. We understand that this is a global event and that as such it has global ramifications. And it is important to get the big picture of what is happening elsewhere. And I think that this is a way to understand the complexity of what we are living through and hopefully to identify some of the trends of where we are going and where society is going following this event, which has affected all of us and transformed our lives. So with this, as usual, we start with a global situation. We like to give attendees an idea of what is happening around the world, and then we will zoom into what is happening in certain countries. So this is the map, which you can, of course, access at Johns Hopkins University. It is a very, very good resource. And these are the numbers. The numbers are big numbers. And we have over 230 million cases that have been diagnosed around the world. And we have about just under 5 million recorded deaths around the world. It has to be said that we have also, as you can see on your right, we have also administered a lot of vaccine doses. You will see over 6 billion vaccine doses have been administered worldwide. So the countries that have been most seriously affected and that have the greatest toll in terms of deaths and of spread are listed on the left, and you will see the United States, India, the United Kingdom, Turkey, and Brazil. And we thought that Brazil was actually an interesting case because unfortunately Brazil has the second highest death toll worldwide. And you might recall at the beginning that they were slow to start administering vaccines. And actually at the beginning, there was an interest or a low interest in bringing vaccines into the country. And at the moment, 60% have had at least one dose, but just 26% are fully vaccinated. And this is not a very good number. There have been very many deaths in excess, and criticisms are reaching the government because some of these deaths, they estimate at least a quarter could have been avoided. In Brazil, they started with a vaccine which was developed in China, known as CoronaVac. And this vaccine also had some issues at the very start. So certainly the high numbers that we are seeing are because in Brazil, there has been a slower reaction and less availability and uptake of vaccine compared to other countries with similar means. Now, another country which has had an incredible surge during the summer is Russia. And also Russia actually had vaccine at the very start. You might remember that in Russia, they produced the Sputnik vaccine, which is the first licensed COVID vaccine, which is now approved in 67 countries. But unfortunately, only 1/4 of the population has received one dose, and 20% have been fully vaccinated. And by the way, we know that COVID-19, or rather the virus, doesn't really care who it infects. And in fact, President Putin is now quarantining after some of the people in his cabinet tested positive. And so we know that there have been several leaders which have been affected by COVID-19. The United Kingdom, we know, has been a hotspot for in several moments of this pandemic. And for those of you who follow the European geopolitical issues, so the United Kingdom is not part of the European Union anymore. It is outside. It is, of course, because of Brexit. And so the Green Pass, or the European passport for vaccination, which has been established in certain countries, actually has not applied in the UK, and they have withdrawn that plan. At the moment, because they were very efficient at the start and starting with their vaccine, they consider to have over 2/3 of the country fully vaccinated, especially the elderly people. Delta variant is fueling the cases, and there is a surge which is believed to be linked to the reopening of schools and active circulation of virus in children. So I mentioned the Delta variant, and I would like to summarize what this variant, how it emerged, and why is it called Delta? Well, it's called Delta because you may recall that the WHO decided to give Greek alphabet letters to the variants to avoid stigma on countries in which those variants were first identified. So it was detected in late 2020 in India, and it caused most likely the third wave in India. And then it was found at the beginning of 2021 in the United Kingdom and in South Africa. And after that, in less than 6 months, it spread virtually to the whole world. And now we can say that it is well represented in 163 countries. And what's the difference with this Delta variant? Well, Delta variant is obviously an evolution of the original strain, and it is twice more contagious than Alpha variant, which was already twice more contagious than the original strain. And so basically, if you consider the virus that we had at the beginning of 2020, which is the original COVID strain, and you consider what we have now, well, Delta variant is believed to be able to infect, one infected person can infect between 4 and 5, while with the original strain, one infected person could infect only a couple of other people. And so Delta variant is very contagious. We are also seeing this in the United States. And this graph shows you how popular, I would say, or how present the Delta variant is in different countries. You will see that most countries that are listed here have virtually over 85 or 90% of their variants that are characterized as Delta. So Delta is now the prevalent virus that is circulating and that is causing problems. So let me move to what are the news around vaccines and what is the talk. Well, first of all, you will see that vaccine uptake is, of course, has this curvy up and down, how can I say, has this pace. You will see that now what we are seeing at a world level is in a lower part of the curve compared to where we were a couple of weeks ago. And you will also see that these numbers that are reported for the world are largely influenced by what is happening in Asia with vaccine uptake, because what is happening in other countries is actually not as significant from a number point of view. Now, one of the concerns that we have and that we have to face is that we have a significant part of the developing world which does not have access to vaccines. And so Dr. Tedros, who is the Director General of the WHO, has called for developed countries to give up their third dose and make this dose available to other countries who do not have access to any vaccine just now. And this is something that is giving headaches to many of the world leaders, because of course, on one hand, and we will hear more about it later with Sonia Rasmussen, on one hand, in the developed world, some of the people need a third dose, and so countries are not particularly willing to give these doses away, and of course, give them away for free. Now, another one of the concerns that we have is should healthcare workers, apart from the most vulnerable parts of the population, get their third dose? And we know that that is important. It is important that healthcare workers are protected. In some countries, in some European countries, this is happening. Certainly, what we can say is that we are seeing the cases that are being seen, the clinical cases that are being seen, are 90% in people who are not fully vaccinated. Now, I mentioned earlier what is happening with developing countries, and you may well have heard that there is this large initiative, COVAX, which is an initiative which is out of a series of UN organizations, and it supplies and it sends vaccines to countries that do not have the capacity themselves or have not been able to provide vaccine for themselves. This is an infrastructure that was developed with an aim to make vaccines available for the whole world. And this was actually before the pandemic. So let's say that there was some thinking before this happened that vaccines did need to be made available. And what their plan is that they would like to be able to have doses for at least 20% of the population of all countries delivered in the short term, hopefully within the next 6 months. And of course, if you look at the numbers that this pandemic is causing us, there are the objective of COVID is of COVAX is to protect even vulnerable countries because of this gigantic economic loss that we are having to go through, which, as you see, has been estimated to be 375 billion every month. Now, what do we know about vaccines and the circulation of Delta variant? Well, what we can say is that there is actually a 10 times greater risk to be hospitalized if you have not had your vaccine. And there is an 11 times greater risk to die of the virus. And although at the very beginning there were some concerns that the protection against Delta variant was not particularly good, actually, we are seeing breakthroughs, as you know, but the vaccine is still efficacious against severe illness. We spoke several times about long COVID, and long COVID is still one of the major concerns that, that we have, because it does appear that symptoms, which you can see here, which are mainly non-specific, but that can get quite serious, can last for over 12 weeks. And one of the things that is concerning is that several people who experience long COVID have problems with their memory and concentration. And of course, this makes things more difficult, especially when you're planning to return to work and to go back to normal life. There was actually a study that pointed out that the IQ could also be lowered by 7 points because of this brain fog. And so it is important that you get your vaccine, and because the vaccine is also capable of preventing long COVID. Unfortunately, my slide's there. In fact, that's what I was saying. If you're fully vaccinated against long COVID, if you're fully vaccinated against COVID, you do not risk or have a much reduced risk of developing long COVID. And this is even for if you have had a breakthrough infection. I would like to mention a few words on the use of this drug, which is called ivermectin. Ivermectin is a drug which some people believe can cure COVID-19. This is not the case. Ivermectin is a drug against parasitic diseases. And what we can say is that the evidence that this drug can actually resolve or cure COVID-19 is not there. The studies are not consistent. But what is happening is that this drug, which is mainly consumed for, or is mainly used and sold for veterinary use, is being used by people who are concerned that they are sick. And actually this drug is toxic and is dangerous for people because the concentrations that you find in veterinary preparations are, of course, be it only for the size of the patient, much higher than what would be a dose for a human being, which in any case would be used to cure a parasitic infection and not COVID-19. So in this moment in which there are so many things that are changing, we thought that we would point out some of the new trends that are emerging. And because we are in a moment of great transformation. And I think this slide is quite interesting because all of us are caught in this, our families and our work and our lives are in this. So you will see that there has been an incredibly sharp rise, the black bar, of the digital interactions after the pandemic. And this is all over the world. And you will see that this, of course, is an acceleration of what was happening, but it is an acceleration that will have ramifications on our everyday life. There are other concerns because we have all been able to experience a different type of working activity because we have been at home for a long time, and so there are questions that are being asked on whether there are new ways of looking at the workforce and out managing the workforce to improve productivity and the well-being of workers. And major companies like a lot of the big tech, the giant tech companies have already moved to long-term remote working. So I think that this is something that we will have to consider and think of, because certainly the digitization that we saw in the previous slide will make a big difference for the future. Now, one of the sectors that, of course, has suffered incredibly is that of air transportation. And air transportation is still, as you can see from the slide on the left, way below where it was in 2019. And several tourist areas and countries are still way below where they were. And this will also certainly change many things as we move forward. Another aspect is that of unemployment that you will see is changing. Unemployment is rising in certain countries, and new jobs, I believe, will emerge and are emerging, especially in countries that are receiving funds to manage this crisis. A few words on COVID and mental health. One of the things that perhaps not many of us expected was that this infection would have ramifications on the mental health of so many people and so many categories of people. And there was very recently an article which analyze the grief and the suffering that is caused by this whole dramatic change in our lives on our mental health. And it is the first time that we experience such a long-lasting collective grief as a world population. But this collective grief is also very personal because each one of us has been affected by this disease in a different way. And of course, this impacts our sense of fulfillment, and we feel frustrated and angry because although we do what we need to do, and although we try and race against the virus, we see that we are seeing breakthroughs, and this is frustrated. And some people actually feel so frustrated by this emergency that they feel as though they were hopeless or totally apathic. And so I think that this is something that we should keep in mind because this affects our students as well as our fellows and our colleagues, and it is a difficult time for everyone. One of the consequences of COVID-19 is anosmia, which means a total loss of smell. And this is quite a distinct feature of this infection. And what what we see is that approximately 10% of people which have developed anosmia, they are still experiencing problems with their sense of smell 6 months later. So it actually is a condition which lasts for a certain period of time and is very disturbing for the people who experience it, because some of them lose interest in food, they put on weight or they lose weight, and they are concerned about this inability to relate actually to other people and to what is surrounding them. Now, a final few slides on what is happening in animals. We only have one update, but we do have an interesting update on the origin. So you might recall that there was an investigation that was carried out, of course, by the WHO, which was heavily criticized. The scientists were sent to China, to Wuhan, and their report was not conclusive. And then the Biden administration put together another investigation team, but also this one was inconclusive. Certainly, what we can say is that the investigation into trying to understand exactly how to trace back the virus started a little bit late, and probably there was a certain degree of circulation in human beings before it was identified. We don't know if there are any progenitors of the virus that are still circulating in animal populations in Asia. And actually, there's an attempt to try and recover blood samples from blood banks in areas that are considered to be at risk for the emergence of the original strain in China to be tested, hopefully before the material is not available anymore. There's an interesting paper which I would like to mention on how the virus possibly, it's not peer reviewed, but it certainly was picked up by a lot of the media. It seems like there are two separate lineages of this virus that are circulating or that were circulating, and this would support the jump from an animal, from a fur animal, perhaps, rather than the laboratory leak hypothesis, which unfortunately is still in place, and this has not been clarified yet. The virus has, of course, spilled over also into our cousins, the gorillas, and there have been 13 cases in Atlanta Zoo. Gorillas basically develop a disease which is similar to that of humans. I wonder if they develop anosmia as well. We will see if they will lose the sense of smell. And most likely these gorillas were infected by a vaccinated personnel in the zoo. But it just shows you that, even if you are vaccinated, you can transmit infections to others who are not vaccinated, be them, in this case, a gorilla, or be it another human being. And with this, I am ready to pass the floor to Sonia Rasmussen. We would like to remind you that we at the One Health Center are respectful of the health of others, and that we try our best to keep the infection away from us. And I wanted to add that we will put out a doodle poll to see what other topics you will be interested in hearing about. We try to do a good job. We try to keep you informed at our best. And Thomas Field, I believe, will ask you what you would like to learn about in the future seminars, and leave it as it is an option as well. So with this, if I can pass the floor to my friend and colleague, Sonja Rasmussen, and I would like to thank you very much for your attention.
Great, thanks. I'm going to be giving an update from the US perspective, and a lot of what I'm talking about today is going to be about boosters, since we've been hearing a lot about boosters lately. So first, where are we at with the pandemic in the United States? Here you can see first wave, second wave, third wave. We're really in the fourth wave, and we're starting to see the effects of some of our mitigation measures of the numbers coming down again. So that's good news, but that doesn't mean we should stop those mitigation measures. Here you can see the community transmission. Even though the numbers are coming down, they're still very high throughout the United States. More than 90 or almost 95% of the United States has what's considered by CDC to be high transmission, and certainly all of Florida. So why is that? You heard from Ilaria about the Delta variant. You can see the Delta variant between June and September really has taken over from all other variants, and that's because it's so transmissible. You can see now it's more than 98% of the variants that are found in the United States. And Ilaria showed you the same picture. What we know is that the Delta variant, compared to the original COVID strain, where the reproduction number, or the R0, was about 2, for the Delta variant, people are saying it's somewhere between 5 and 8. So I'm just going to show you a picture here of what does that effect of the reproduction number or of the R0. You know, the original virus went to 2 people, 2 goes to 2 more, so that's 4 people, 8, 16, 32. You can see the effects. I picked a number in the middle of the 5 to 8. Most people are saying 5 to 8. Some people are saying even 9 or 10. You can see one person with the Delta variant gives it to 6 other people. 6 other people give it to 6 more, so that's 36. You can see how quickly the numbers really go up, really fast. You can see have lots and lots of people. So we know that there are 3 vaccines that are available in the United States, 2 mRNA vaccines that are 2 doses, and then the Janssen vaccine that is 1 dose now, although there's recent data that the second dose is helpful and improves the effects. These are the initial efficacy based on the randomized clinical trials, 95%, 94% against symptomatic, and then 66% for Janssen. What we're seeing now is some waning of this effect. It's difficult to know if it's waning of the effect or if it's the Delta variant is enough different that there's being some vaccine evasion. And I'll show you some of those data in a minute. The other thing to note is that all 3 received emergency use authorization from FDA. And then on August 23rd, the FDA gave full approval to the Pfizer COVID vaccine for people 16 years of age and older. And you probably heard that the Pfizer has now submitted their data for children under the age of 12. So 12 to 15, right now there is emergency use authorization, and then 5 to 11-year-olds, there are data ready from Pfizer, and they need to be reviewed by FDA and then by CDC. So this is the change in the number of doses given in the United States. You can see initially, you remember when everybody was fighting to get their vaccine, who got it first, a lot of work trying to figure out what the order of people should be. And then you can see here where the numbers really rapidly dropped. And then recently, with the increase in the Delta variant, people started getting interested in getting vaccinated again. And then we're having a easing off again. And really, as we've said, I think from the very start, the way to end this pandemic is going to be vaccination. So this is from a few days ago, but this is the update. 64% of people in the United States have had at least one dose, 55% are fully vaccinated. But remember, right now, kids under the age of 12 are not even they're not authorized to get the vaccine. So of people who are eligible to get the vaccine, about 3/4 have gotten at least one dose, and 65% are fully vaccinated. So we need to keep working on the remainder of those people that need more information to feel comfortable about getting the vaccine. So what do we know about the vaccines and the Delta variant? We do know still that fully vaccinated people are less likely to get infected. So if you're unvaccinated, you're about 5 times more likely to get that virus in your nose. So what that tells us is that initially it appeared that that vaccination reduced the risk of infection, at least of symptomatic infection, to very low numbers. But now we know either because of waning or because of the Delta variant that breakthrough infections can occur. What we do know is that the risk of hospitalizations remain low, and it really depends on, this is a study from Los Angeles, it depends on the study, but the studies are pretty consistent that people who are unvaccinated are at least 10 times more likely. This study said 29 times, but most of the studies are saying at least 10 times more likely to be hospitalized and more than 10 times as likely to die. So one of the concerns, though, as you know, people who are vaccinated can have virus in their nose. And I think some of that is that the Delta virus is so much more transmissible. It can get in people's noses, doesn't usually get in their bodies to make them sick if they're vaccinated, but they can have virus in their nose and they can pass it on to the others. And of course, that's why we need people to keep wearing masks when they're indoors. The vaccines in general are still highly protected against severe disease, hospitalizations, and deaths. So what do we know about boosters? And I want to say at the start, some of these slides are from unpublished data, and they are directly, I took the slide from some of the CDC presentations. I tried to put a note at the bottom when I did that because they're unpublished, and so that was the only place I could get them from. But here you can see there's been a lot of, I think, confusing messages for people. In August, the White House announced that the COVID vaccine booster shots were going to be available for all Americans. Then people started saying, well, what about the FDA approval? What about ACIP approval? There was the recommendation, the promise that everything would be science-based. And then they said, that this all depends on FDA and CDC approval. So the FDA committee, the VRBPAC, the Vaccines and Related Biological Products Advisory Committee, met and they voted for COVID-19 vaccine boosters, but for limited populations. And I'll tell you about those limited populations. The advisory committee to CDC, the Advisory Committee on Immunization Practices. So both of these advisory committees are outside. They're primarily actually academics who give advice to FDA and to CDC. And the advisory committee recommended that certain people receive COVID-19 boosters. One of the surprising things, I think, for most people is that they did not recommend them based on occupation or institutional settings. So it meant, for example, healthcare providers were not recommended to get it. That was a fairly close vote. It was 6-9 against giving those vaccine boosters to people like healthcare providers. The CDC director has the final say, and she did overrule that, approve boosters for a group of populations, which I'll give you the details about in a few minutes. Most of what she said was consistent with her advisory committee, with the CDC's advisory committee, but the one thing that was different was the occupation and institutional settings that I'll show you in a minute. So everything about vaccine boosters is like everything with vaccines. You're trying to weigh the benefits and the risks, and you want to be sure that the benefits are greater than the potential risks. And that is what the discussion was about at both. I listened both to the VRBPAC meeting and to the ACIP meeting, and that was really what they were focusing on. What do we know about, do people need boosters? And then is getting boosters, is it safe to get boosters? So just to start, this shows that most people in the United States have received Pfizer. And so the statement about boosters right now only applies to people who've gotten the Pfizer vaccine. Fewer people have gotten Moderna, and then even fewer have gotten Janssen. And you'll see that the Janssen J&J vaccine, because of the fewer people, some of the numbers are pretty unstable. This is a study that CDC presented at the meeting. It's not been published yet, and so it has one of those stickers that I put on that says I took these from the CDC call. Increasing community access to testing partnership. It's a partnership between CDC and some pharmacies and some other partners. And they asked people self-reported vaccine history at the time that they registered to get COVID-19 testing. And then they were able to adjust for day, race, ethnicity, sex, the site's HHS region and state, and so on. But they did not adjust for underlying conditions or prior infection. So what they showed here, and you can see they have the green is pre-Delta. This is time from getting your second dose, because you can imagine if it's waning, the further time away from your second dose, you're going to start seeing some diminished vaccine efficacy or vaccine effectiveness. So the VE, vaccine effectiveness, you can see here, the green is pre-Delta, the red is in the time of Delta. What you can see is that there does appear to be some waning even in pre-Delta times. So you can see in all age groups, you can see that the waning is the most significant. Well, this I'll show you in the next slide, but you can see that there is some waning in all age groups for infection, for symptomatic infection. This is for Moderna. Moderna seems to be having less waning. And as you remember, Moderna had a higher dose, and there seems to be less waning involved with Moderna vaccine. And then Johnson & Johnson, these numbers are kind of all over the place. And I think that's in part because the numbers were smaller. So these are the limitations for this study. It's self-reported. They didn't do any clinical assessment. It's people showing up, saying they have symptoms and they want to be tested by, for example, a pharmacy. No information on whether they had comorbidities, no information on prior infection, no information on risk behaviors. And there's no genetic sequencing results. So they don't know that it was Delta. All they know is the time period that they considered pre-Delta and then Delta, although you can see from the numbers that I showed you earlier that the later period, it's almost certainly Delta, because everything is almost certainly Delta at that point. So this, I think, is really the interesting part. They looked at, this is for people 65 years and older, and these are a number of different studies, and they presented all of them, but I knew I wouldn't have time to present all of them today. There's not much data for people with underlying medical conditions, and then there's not much information for frontline workers. Here you can see that both for infection, the blue lines, and for hospitalization, for people 65 years and older, we're starting to see some diminishment of the vaccine effectiveness. So I think that's what's really important. I think this is the group that most is in need of a booster right now. There wasn't much information on underlying medical conditions. There was just one study. That study certainly didn't look like we were in desperate need of vaccines for underlying medical conditions. And then there was just one study for frontline workers, like healthcare workers, and that showed a diminishment for infection, but did not look at hospitalization. So our booster dose is needed. I think the evidence is pretty good that people 65 years and older need a booster. There were significant declines in vaccine effectiveness against infection during the Delta variant period and for hospitalization. And it looks like the waning period is about 6 months after the person got their second dose. So there is evidence of waning immunity. There's probably some less less vaccine effectiveness with Delta, but really the thought is that it's primarily waning immunity, or at least that was the way I took the conversations. For people with underlying conditions, there really wasn't a lot of good data to support it. For occupations, there wasn't great data to support, that should be SARS-CoV-2. That wasn't great data for that either. So are boosters safe? And a lot of people have said to me, well, dose 1 and 2 were safe. Why would dose 3 not be safe? And I think the one thing people are worried about is if We know that dose 2 had a greater risk of myocarditis than dose 1 did. What if dose 3 has an even higher rate of myocarditis? And what they've looked at, they have data from Pfizer-BioNTech phase 3 clinical trial, but it only included 306 people. There are data from VAERS and VSafe, the 2 safety studies about people who have gotten the 3rd dose. And all of them are reassuring. There were no unexpected patterns of adverse events identified. But remember that we're looking for something that occurs 3.5 times out of a million second doses. So will we see it in these small numbers that have been studied so far? Maybe not. So right now, no unexpected patterns. 95% of the reports from VAERS, and you remember VAERS is a vaccine adverse event reporting system. That study can't determine if it's associated or not. It's just people reporting anything, and anyone that has concerns about something that they've had after the vaccine, you can report yourself. It doesn't have to be reported by a physician. And then they do have data on over 22,000 VSafe registrants who have reported an additional dose. And most said they had gotten a vaccine, like they'd gotten Pfizer before, they got Pfizer second, or Pfizer for the 3rd dose. And their local reactions were slightly less frequent, slightly more frequent, like having a sore arm, and systemic reactions were slightly less frequent following dose 3 than dose 2. And that was similar to the Pfizer clinical trial. So basically, on the information we have right now, booster doses do look safe. They're needed for some persons in the population, but probably not all. So just as a reminder, this is the myocarditis safety signal. We're talking really about Pfizer right now, because that's the company that has come forth first with data and has asked to be able to give booster doses. And as a reminder, that risk of myocarditis is highest in males that are 18 to 29 years, and it's in all the population, the risk is 3.5 cases per million doses. So this is from the Advisory Community Immunization Practices presentation. This is the number that would be needed to vaccinate to prevent 1 hospitalization. This is like the number needed to treat that you may remember from epidemiology class. You can see for people 65 and older, it's about 500 people. But as you get younger, you're going to need to vaccinate a lot more people to prevent 1 hospitalization. So this is the summary of the risks and the benefits. This was from the call that CDC had yesterday. As I said, the potential risks, they believe there are very rare risks of myocarditis and pericarditis, particularly in males in that 18 to 29 year age category. Seems like anaphylaxis is going to be unlikely. If you didn't have an anaphylactic response to the first 2, seems unlikely that you would to the 3rd dose. The reactogenicity seems to be similar, that fever, sore arm, etc. The potential benefits here, it does appear that people who got a booster dose based on data from Israel, where they have given a lot of booster doses, that there does appear to be a reduced risk of infection and a reduced risk of severe disease. The strongest evidence for reductions in the risk of severe disease is in older adults, people 65 and older. And for younger people, really that primary vaccine series is still doing a great job at keeping you from getting severely ill or ending up in the hospital, or definitely for dying. There does appear to be a reduced risk of SARS-CoV-2 infection. And so there was a lot of discussion about, is this important to reduce the transmission in the United States right now as we're seeing more transmission? We don't have great data on that right now. And really, the bottom line that they discussed is the way to reduce transmission of the virus in the United States right now is for more people to get vaccinated, not so much the boosters. So this was the ACIP work group interpretation. Again, I've just taken their slide directly. The top priority should be trying to vaccinate unvaccinated individuals. That's the best way to slow down transmission in the United States and get our lives back to normal. The balance of the benefits and the risks varies by age, with people 65 and older having the clearest benefit. And then the goal of the booster program should continue to be prevention of severe disease, although other considerations were discussed, that you can maintain the workforce. For example, if you have a bunch of people in the workforce and the healthcare providers getting sick, you may not have enough nurses and doctors to take care of patients. And they also talked about prevention of transmission. So as a reminder, there are different levels. First of all, the data comes from the company, then FDA reviews it. FDA has that VRPAC advisory committee, and then CDC does a review. First, their advisory committee, and then the CDC director makes the final decisions. And this is what they came up with. These are the people that should receive a booster dose. This is if they got the 2-dose Pfizer series before. This is not the case for Moderna. And they should get it at least 6 months after completion of their 2-dose Pfizer series. They should get a booster shot of Pfizer, not Moderna. And for people 65 years and older, people who live in long-term care settings like nursing homes, and then people who are aged 50 to 64 years with underlying medical conditions. People who may receive a Pfizer vaccine booster, and that should be people weighing their benefits and their risks. That includes people 18 to 49 who have underlying medical conditions. As you saw, the data are not great for that. And then 18 to 64 who are at increased risk of exposure based on their occupational or institutional setting. And people can talk with their healthcare provider about whether getting a booster shot is appropriate for them. So these are the occupations: first responders, healthcare workers, firefighters, police, teachers, education staff, food and agriculture workers, manufacturer workers, corrections workers, U.S. Postal Service, public transit, and grocery store workers. And they say that the list could be updated in the future. I think given the time, since we're close to the end, I'm going to skip the discussion of masks.